The Kellerman Foundation was created to address the immense needs of the indigenous Batwa Pygmies who were displaced from the Bwindi Impenetrable Forest in 1992. The Kellerman's early mission focus was on saving lives. As resources grew, we made healthcare available to the entire local population and broadened our efforts for the minority Batwa, providing education, protecting clean water sources, building homes, and setting up vocational training. Our practical Christian approach calls us to implement sustainable solutions to change the root causes of extreme poverty and poor health. Local and international partnerships help us expand and enrich our services in this remote region. The Bwindi area is one of the poorest in sub-Saharan Africa. We battle poverty's effects through healthcare, community education, nurses training, school opportunities, vocational training, and spiritual outreach. Our long-term objectives, which will require substantial funding, supporters, and partnerships, are to significantly reduce the burden of disease and disability, improve agriculture and vocational opportunities, and measurably improve the general welfare of this impoverished region. Our very long-term goal, probably not achievable in my lifetime, but one I hope and pray for, is to work ourselves out of a job in southwest Uganda. Bwindi Community Hospital, founded by Dr. Kellerman, consistently ranks among the best performing hospitals in Uganda. All our programs are run by capable, committed Ugandans and strengthened by partnerships that increase our effectiveness. For example, an innovative collaboration with traditional healers significantly improved TB patients' treatment compliance. In 2012, 97% of TB patients completed their treatment, far exceeding Millennium Development Goals. We take a broad-based approach that helps improve community understanding of health, nutrition, and education principles. The negative effects of extreme poverty are often partly due to poverty of knowledge. Our programs tackle that head-on. Our board and staff are chosen for their committed, collaborative approaches to problem solving. Our programs on the ground are run by some of the best and brightest in Uganda. We learned the hard way that imposing a Western model to solve problems and address local needs is rarely successful. Instead, our programs are designed with the input of Ugandan staff members who discuss them with the constituents they serve. Mid-course corrections are accepted and encouraged. We stay flexible yet focused on our ultimate goals of providing hope and health. The hospital, nursing school, and Batwa development program in Uganda all provide our U.S. staff with regular reports and financials to demonstrate program success. Both qualitative and quantitative analysis methods are used. Success stories and challenges are outlined in detail. The hospital uses a sophisticated data gathering system implemented by Colgate University, which provides family demographics, illness tracking, and even GPS locations for homes in this region of remote, far-flung villages. Some of the statistics are very encouraging. For instance, in 2012, 91% of children born to HIV-positive mothers were HIV-free at discharge, and 97% of TB patients completed treatment. Scott and Carol Kellerman are the heart and soul of our organization, and their early vision continues to drive us. But our work is more than what two people can contribute. Our worldwide network of support has let us exponentially expand the Kellerman's impact. We've achieved significant, some say miraculous, changes in a relatively short period of time. This is due to three factors. First, our focus on prayerfully discerning where and how we serve. Second, a collaborative approach based on realistic needs assessments. And third, building strategic partnerships that broaden our reach and produce lasting change. One of the best nursing schools in Uganda was built in just 2.5 years through partnerships with 2 dedicated entrepreneurs who have a visionary approach to social development. Bwindi Community Hospital is among the most successful in sub-Saharan Africa for infant and child intervention, maternal health, HIV/AIDS and TB treatment, and malaria reduction. And in 1 generation, we've helped the Batwa Pygmies move from near extinction to a life of hope and dignity. Under 5 mortality dropped from 38% to only 6% in 12 years. In the 90s, the Batwa had no formal schooling. By 2013, 1 had graduated from college, with others close behind. Working in sub-Saharan Africa is rarely easy. We contend with poor roads, inadequate communications technology, shifting political priorities, complex tribal interactions, and occasional lack of financial accountability. All these factors are taken into consideration as we design our programs. Financial issues have been addressed head-on, with strict accounting and audit guidelines and training in Western financial expectations, so we can clearly show that our funds are spent as directed. Ugandan staff members give us insight into where projects might stall or how to approach difficulties. And having long-term American volunteers and missionaries on the ground keeps lines of communication open. Additional financial and partnership resources would first be used to strengthen our existing programs, such as educating more nurses, sending more children to school, empowering more Batwa to earn a living, and giving more residents access to health care. By building a strong base and telling our story to new people, these programs could more effectively serve this impoverished region where every dollar makes a difference. Secondary uses would be to build permanent homes for more Batwa families, purchase additional land for settlements, and increase agricultural and animal husbandry training. This would help families improve health and provide better options for becoming self-sufficient. The needs in the Bwindi area are great, and opportunities to make a difference almost endless. Given additional financial, personnel, and volunteer resources, we'd carefully weigh the areas where we could have the greatest long-term impact, and, more importantly, ask our constituents where they see the most urgent needs. Options might be to build and staff more clinics, provide education funding for more students, and expand hospital and nursing school programs. We could also address sanitation and water improvements, community-based savings and loan programs, land usage, or family development opportunities. Matching needs and resources is the key to success.